It's a real pleasure again being here, and congratulations for the Düsseldorf team on a splendid meeting and successful meeting. So these are my conflict of interests. So I would like to address two issues in this talk. It's management of Barretts in general. So I would also like to address management of non-dysplastic, where I think the theme of less is more needs to be emphasized. So first, we need to make fewer diagnoses of Barrett's esophagus. So we need to step away from these very ultra-short segment Barrett's. So we only diagnose something as Barrett's when it's more than 1 centimeter and contains intestinal metaplasia. So, and especially to the trainees in the room, it is important to emphasize not to over-insufflate too much. Because in fact, if you look at these two pictures, they're exactly the same patient. But because of over-insufflation, you may actually over-diagnose Barrett's. We took a biopsy of this tiny little tongue here, which contained intestinal metaplasia, but because of the new diagnosis, this is not longer recognized as a Barrett's esophagus and doesn't need to be followed up. So just take biopsies only when you see something that is suspicious, like lesions. And the reason for that actually comes from a very nice multi-center study in Germany, where they looked at what is the risk of this very ultra-short segment Barrett's. And it's really negligible. So we need to focus and put our efforts in those at risk with longer segment Barrett's, because as you can see here, actually, in order to find neoplasia, you need to do almost 13,000 endoscopies in these ultra-short segment Barrett's. And this actually nicely corresponds to the very old definition of a regular Z-line by Savory Miller and Denardi and Riddell, which actually indicated that the Z-line is normally serrated with 4 to 6 small projections into the esophagus. So this actually corresponds back to what previously was already regarded as normal. We need to follow up real Barrett's, and this depends on the length according to the ESG guidelines, which you can see here. Up to 3 centimeters every 5 years is enough, above 3 centimeters every 3 years. And for the long segment Barrett's, this risk is actually comparable to the progression rate of low-grade dysplasia. So you may envision that maybe an experienced center should follow up these longer segment Barrett's. Very important to emphasize is there is no indication for treatment of non-dysplastic Barrett's. It's absolutely not cost-effective. It may actually not prevent cancer in the end, and the risk of progression does simply not outbalance the side effects that may occur during treatment. All the guidelines still include the Seattle protocol, and this still needs to be done, but obviously it's not only about taking biopsies, you need to look properly. I would like to advertise this interesting BORN project that was published last year, a validated training program that showed nicely, if you are exposed to 4 different batches of 20 videos, that your correspondence with expert delineations in videos online actually increases over time, as you can see, from 49% to 82% expert agreement in the end. So anyone can train in this. So less experienced endoscopists participated in this, and even trainees. And the nice thing is that it is now freely accessible and available. It's even CME accredited. And online you can go, and if pullback videos, you can indicate where to take a biopsy. And subsequently, when you've found something, you can be asked to delineate that area, and you can actually check how 3 other experts delineated that, which is also a bit of a sobering experience, because you can see the disagreement between the experts itself, again indicating what we discussed this morning, how difficult it can be to delineate Barrett's esophagus. Okay. So I think we should also use advanced imaging during surveillance. I think especially there is a revival of acetic acid, which actually can serve as a red flag technique. The most recent trial, the ABBA trial from Portsmouth, addressed this for the first time in a low prevalence surveillance population, where patients were randomized between a standard Seattle protocol and targeted biopsies with acetic acid in 2 different endoscopies. And what was shown is actually that you have almost a 10-fold reduction in the number of biopsies to find high-grade dysplasia. And what is more important is that important pathology like cancer and high-grade dysplasia was not missed in this pilot trial with acetic acid. And it really works well. You can see an example here, even for previous generations. So this is an Olympus 180 series. which is already high definition. But if you put on the acetic acid, you can nicely see here the spot that is not stained, and this actually is a small cancer. The use of advanced imaging will also improve the quality, because in order to perform advanced imaging with MBI, BLI, or iScan OE, you need to clean the esophagus, and that is really mandatory to unreveal all those lesions that might be there. And according to this study from Nottingham, you can see that the use of high-definition endoscope increases actually the number of lesions detected or the dysplasia on targeted biopsies in this retrospective analysis. Advanced imaging takes also more time because you need to switch between modalities, you need to clean, and time is of essence, as we know, for finding these lesions according to this study from Nick Shaheen's group, Pratik Sharma's group, indicating if you spend 1 centimeter per circumferential Barretts that you have an increase in detection. And this is also a quality indicator for endoscopy. Advanced imaging provides a better contrast image. Probably it will be hard to indicate we will detect more in experienced and enriched centers and enriched populations. But if you just look objectively to the different movies that you see here, every information is obviously there in the standard white light image that you can see here. But that small irregularity that will appear here at the 12 o'clock just stands out better if you use a bit of surface enhancement or if you use contrast enhancement and an optical filter like in the iScan OE. And just recently, in the lately published Blink classification, this was also highlighted. There are some new indications looking at subjective appreciation of the new imaging modalities, and this compares BLI and white light images. And you can see that the appreciation for the Paris classification of the surface relief and the ability to delineate lesions was better for BLI. And just an overall preference for appreciation of the relief and the ability to delineate lesions was significantly higher for BLI. This was first published for experts or experienced endoscopists and subsequently tested also in less experienced endoscopists that are not generally performing Barrett's therapy. So this is now well established. And we can then also pay with these techniques more attention to subtle changes in surface morphology and specifically color. The latter has been highlighted in the most recent classification. We know the Bing classification, the iScan London classification that talks about mucosal and vascular regularities or irregularities. But in the latest Blink classification, they actually added color, focal darkness, as one of the neoplastic features. Just to illustrate this pull-through in a BLI video, you can appreciate the lesion here appearing at the 6 o'clock position, and notice this dark halo around this slightly depressed lesion. And you can say, yeah, that's easy to find. But just let's compare it to the white light image here, where obviously there is a lesion visible, but just adding this, you can see this contrast that allows you to delineate the entire extent of the lesion easily. So this is an interesting feature that has been highlighted in the most recent classification. In the future, I think we'll move to other techniques, and one of the promising techniques, I think, is this Watts 3D technique that gives a deep mucosal brushing and gives an entire sampling of a Barrett's segment. And it is incorporated, we talked already a lot about artificial intelligence, and this has been combined with a computer analysis that, based on an algorithm, will present the 100 most suspicious slides to the pathologist for assessment. And it has been shown in several studies now that the adjunction of this Watts 3D biopsy into standard Seattle protocol biopsy increases the yield for detection of neoplasia and Barrett's. In the future, we will have more artificial intelligence. One of the projects I want to highlight is that from Argus, from Holland, which was a supervised training program. You can identify the sweet spot, which is where all the experts, 6 experts agreed, and then the soft spot where any expert would indicate something. And this algorithm had already a good accuracy in localizing visible lesions and also having really a good indication for where the worst pathology was. And then we have this interesting development from Augsburg, where they developed, based on ImageNet pre-trained images, and validated this system in 36 early cancers and 26 normal Barrett's patients and 40 patients, looking at a good sensitivity and specificity. But I think if you see, it's like more characterizing here, so probably the detection tool will be the major challenge, but look how nicely this works. So the higher the color intensity here, the higher the probability of finding a cancer. So this is the way forward, and this is what we will be using in time. So less is more, less frequent surveillance based on the length of the Barrett, less overdiagnosis, and more time, more techniques we need to use, and we need more training, which is all available. Now let's move to the standards in treatment. The first thing is all visible lesions need to be removed regardless of the degree of dysplasia. This is in the ESG guideline. And why is this? Because only histology will give us an idea if we are dealing with the right patient to treat with an endoluminal therapy. In particular, the depth of infiltration needs to be assessed, the lymphovascular infiltration, differentiation grade, and this gives us an idea about the possible involvement of lymph node metastasis in this patient. And this is why it is so crucial. And just from a clinical perspective, it has been shown in the UK registry that increasing the amount of endoscopic resection safeguards the oncological outcome of the endoluminal treatment in Barrett's neoplasia. As you can see in this study, there was an increase to 60% from 48% over a different time period, and this corresponded to an increase of complete remission of dysplasia from 77 to 92%. So it's really mandatory. The Barrett's you saw this morning is not something you can ablate, because the accuracy of pre-EMR biopsies, only if it shows high-grade dysplasia, is not enough. In 20% of the cases, you will have an upgrade of the disease, and if you see those friable changes we showed you this morning, there's a very high chance there will be cancer. Just an example, this is a 51-year-old policeman that was referred with with high-grade dysplasia, where we found a small lesion showing high grade on biopsies. But during the EMR and after the EMR, actually the lesion had grown a little bit before the EMR. You can see that we were dealing actually with a submucosally invading, poorly differentiated cancer. So if you're going to treat this patient based solely on the diagnosis, what was based on the biopsy, you may miss out the opportunity for a curative resection. Endoscopic resection is the first choice for early adenocarcinoma, and EMR is the preferred resection technique. So why is this? We have this excellent series of 1,000 patients from Wiesbaden that show that although you need multiple resections, you can get a complete remission of neoplasia in 96%. There's a recurrence during follow-up, but long-term complete remission with this technique is excellent, 94%. And this is comparable to what you would achieve with surgery in the same setting of patients, although surgery has a higher morbidity. In this case, there was one patient that died, and the safety of EMR is very good. There's a perforation rate of 1% and delayed bleeding rate of about 0.5%, 1 in 200. ESD is feasible, but for most lesions, we don't need it. And that has been nicely shown in this study here from Düsseldorf, where patients were randomized between EMR and ESD. It's highly criticized because of the size of the lesions and so on, but it's good science, a randomized trial showing indeed a higher R0 resection rate for ESD, but this did not result in a better complete remission of dysplasia, which in fact is the hard endpoint for the patient. There were more severe adverse events in ESD, but I think, however, that the role of ESD in the future will be to deal with patients with more advanced disease. Because although the risk of submucosal invasion increases the risk of lymph node adenopathies, you still may say that if you have an SM2 cancer who has 20% risk of submucosal invasion, they can be actually cured in 80% of the cases. So if we're dealing with an elderly patient with comorbidities, I think ESD is an excellent choice for those more nasty-looking lesions. So in the ESG guidelines, it's still there, but this will be revised in the coming year and see what comes out of that. And then RFA is the preferred ablation method at this stage. So for residual ablation of residual Barrett's after removal of visible lesions, or for flat high-grade or low-grade. I just summarize here briefly the results of 3 different trials, the Euro 2 UK registry and our own registry, where you can see that complete remission rate is high, ranging from 83% to 93% to a microscopic eradication of all Barrett's. And for dysplasia, it goes up to 98% and lowest level 92%. Very good safety results. Stenosis can be an issue in up to 10% of the cases. And you also need to warn your patients, we don't mention that too often, I think, that there may be actually a risk of 2% delayed bleeding, usually 7 to 14 days after the treatment. What about low-grade dysplasia? This is a difficult diagnosis, needs to be confirmed first. So we want to at least have 2-3 pathologists deciding that it's actually dysplasia, low-grade dysplasia, on 2 different occasions according to the EG guidelines. And then you need to discuss whether you want to treat these patients, because we have the SURF trial where patients like this were randomized between active ablation and follow-up, showing a significant higher progression to adenocarcinoma high grade after 2 years in 26% of the cases. So it's mentioned that RFA is the preferred method in the guideline, and this is because of the evidence that's available. So the only way for primary RFA is to have a confirmed high-grade or low-grade dysplasia without absolutely no visible lesions, but in all the other cases you need to resect that and assess the histology to see if you're on the right track and then add on RFA. Just want to mention briefly the current RFA regimens. So we have now this new balloon self-sizer. Just remember there's no room for a simplified protocol. Be careful with the catheter. If you take it out, you need to turn it clockwise and use no force. Some perforations have been described by the company if this was done wrongly. So we tried to assess if we could go for a simplified protocol with a double hit 10 joules, but unfortunately this caused too many stenosis, so we had to abandon that arm. And when we compared the single hit versus the 10 joule clean 10 joule hit, unfortunately this was less effective in having regression of the Barretts, and we had indeed significant more pore healers in that arm. So you need to clean the esophagus, burn once, then clean everything with a cap, you clean the catheter, you go in for your second hit. For the simplified protocol, we can actually apply that for the focal catheter, a triple 12 joules, which was studied in this non-inferiority trial that showed a simple and comparable regression without more complications of stenosis. So a triple 12 joules seems to be appropriate for the focal catheters. Other ablation methods in this era, we have the hybrid APC. One of the misconceptions, I think, in the risk of APC and hybrid APC in general is that it's easy accessible. Easy accessible does not necessarily mean I can easily do this. So if you're going to use it, please go back to the protocols that were used and apply that. It's not just one single hit of something. No, you lift, you burn the first time, then you scrape everything off of the coagulum, and you go back with a lower energy setting for a second ablation until you have a yellow coagulum. And the first results from Wiesbaden were promising. You can see them here, and per protocol regression rate endoscopically of 96% and histologically of 78%. And we have also now the results of this multi-center German trial from Thomas Rush that were published. These are the results published at the German national meeting, where they have now a follow-up of 180 patients with 2 years follow-up. So the protocol was comparable to Euro 2 and SURF, where first EMR was performed and subsequent maximum 5 sessions of APC. That succeeded in 93% of the patients. And of those patients of follow-up, you can see that during 2 years follow-up, there was recurrences in 24% of the cases and only 3 neoplastic lesions. In terms of complications, there was 1 perforation, 7 bleedings, 10 fever patients, and 6 stenosis. So I think this is quite comparable if you look at it to RFA. The Bright study assessed general APC with a similar efficacy and safety, but it was a little bit less cost. And then we have the cryoablation that may actually have a role in those refractory cases. So this is one patient from Imicanto where there were 44 refractory patients to other therapies, and 2 recent meta-analyses actually suggest a similar possible role for liquid nitrogen and cryoablation in general. So there may be future roles for this, but we need to find the exact place of these other techniques. As for the technique that I showed you yesterday, it's similar. So this is the cryoablation balloon with nitric oxide that you saw yesterday. The results are preliminary at this stage that have been published. published. What we see is around 90-95% complete remission rate for dysplasia and 84% for intestinal metaplasia. Safety issues are there. Minor lacerations can occur, and a few perforations have been reported, and the stricture rate is apparently quite comparable to what you can see after APC and RFA. The pain score, however, is less for this technique, so wait for the Your-Cold-Pay trial that's on the way. Close follow-up remains necessary. The risk of recurrence is 32% and 90% neoplasia according to the AIM dysplasia trial, and mostly occurs within 1 year. And most of them are situated in the distal part of the esophagus, and especially the cardia is an area of predilection where it's hard to detect, so we always take biopsies of the cardia after the entire treatment. So the standards in treatment of Barrett's neoplasia here, more is better. Make more EMR because it makes the treatment endoscopically safer, and more eradication of residual Barrett's gives less recurrences in the long run. In conclusion, avoid overdiagnosis of Barrett's and adhere to the follow-up guidelines. Use advanced imaging during surveillance. We know that mucosal and slightly submucosal cancers that are well to moderately differentiated without lymphovascular infiltration can be safely resected in piecemeal EMR followed by add-on ablation for Barrett's. ESD is probably more indicated for resection of more advanced lesions to attempt a curative local treatment. ER of visible lesions is mandatory to safeguard the good oncological outcome of RFA and Barrett's neoplasia. These lesions are difficult to detect, as we know, so get your training online with the bond module. I think this can also be beneficial for your surveillance practice, and meticulous follow-up remains necessary after treatment. Thank you very much for your attention.